some of the things that Dr. Devine already touched on. And then if there's time, I'd also like to address one of the questions that was asked of Dr. Devine regarding whether or not patients are mentally ready to enter into addiction treatment and recovery and how safe supply fits into that. So first, just very briefly, in the late 1990s in the United States, there was widespread recognition that we were not doing a good job treating patients with pain. And there was a mantra about the undertreatment of pain and a strong sense of urgency around wanting to do better. And this was a real and true thing in medicine and in the state of pain care. But what wasn't real and what wasn't true was that opioids prescribed more liberally by doctors in the treatment of pain would solve this problem. And so there was an enormous mismatch between the evidence and this sense of urgency and wanting to really help people with a very serious problem. In fact, the evidence that was used to support more liberal prescribing of opioids for the treatment of minor and chronic pain conditions consisted of very poor evidence. And of course, you've heard already from Dr. Devine the ways in which the evidence in favor of safe supply are really not adequate data sources. They're biased. They don't really look more broadly at what's happening in the communities where safe supply is being offered, what happens to the people who drop out of those studies. So I just really urge this committee to be very careful and very thoughtful when thinking about safe supply, to acknowledge the fact that we are in the midst of an opioid epidemic, that people are dying, and of course we all care about that problem. But that sense of urgency that we feel to solve it shouldn't cover our eyes to the fact that safe supply is not well supported by the evidence, that one of the biggest risk factors for addiction to anything is simple access to that drug, and that we in fact already tried this experiment of more liberally prescribing opioids for pain, and that in fact is what caused our opioid epidemic. Second, I'd like to talk about buprenorphine and methadone maintenance and how they are different from things like heroin and hydromorphone. So one of the main factors in addiction is that people are caught in this endless cycle of intoxication, withdrawal, craving, drug seeking, intoxication, withdrawal, craving, drug seeking. And that consumes all of their energy and creativity and is the essence of what we talk about when we talk about the hijacked brain, that really those limbic and reward centers have taken over the gray matter cortex, and people are living in their lizard brain, which is sometimes the way we refer to the triune brain, or this very primitive pleasure, pain, reward system. They're no longer able to access their frontal lobe function, their delayed gratification and future planning function. So what we need to do is get them out of that state, right? And one of the ways that we can do that is with sustained abstinence. Of course, that's very painful in the beginning. There's intense craving. But when people get over that state and start to get their frontal lobes back online, then they have real agency and they can again make informed choices. What methadone maintenance and buprenorphine have is very important, unique properties as opioids, is that they have a very long half-life. So they remain in the system for longer than 24 hours once they get to steady state. That means people are no longer in this cycle of intoxication, withdrawal, drug seeking, intoxication, and withdrawal, drug seeking that rules their whole day. They're able to achieve a steady state blood level, which then allows them to enter into other recovery activities. So this is really a fundamental and important difference, and you can see this on any kind of metabolic graph of how methadone and buprenorphine work in the system. They have this long half-life. In addition to that, buprenorphine has two other properties that make it a very unique and very safe opioid, and hence appropriate in the use in the treatment of opioid use disorder. Buprenorphine has what we call a very strong binding affinity. So if this is the opioid receptor, then this is buprenorphine. Buprenorphine is an opioid. It binds that opioid receptor very, very tightly, such that it acts as an antagonist on that receptor so that other opioids can't get in. So what you have is buprenorphine binding the opioid receptor, stimulating the opioid receptor, causing that relief from craving, but at the same time, if an individual on buprenorphine uses heroin or uses hydromorphone, the heroin and the hydromorphone can't get in because buprenorphine is effectively acting to block that receptor. Third, buprenorphine has a ceiling effect on respiratory depression. So how is it that people die from opioids? Opioids have three main impacts on the brain. Number one, they, in the short term, relieve physical pain. Number two, they cause euphoria by releasing a whole lot of dopamine in our brain's reward pathway. And number three, they work on the lower brainstem functions to slow down the heart rate and slow down respiration. So when people take more opioids than their brain can tolerate, then they slow down their breathing, they slow down their heart rate, they fall asleep, and they don't wake up again. And over time, as Dr. Devine talked about, people need more and more of their drug to get the same effect in terms of the euphoria and the pain relief, and they build up tolerance. But they don't build up the same kind of tolerance at the same rate to the respiratory suppressant effect. So as they're escalating the dose over time to get that good feeling or to get pain relief, they're slowing down their heart rate, they're slowing down their respiratory rate, and eventually it's too much and they accidentally overdose and die. Buprenorphine has a ceiling effect on respiratory suppression. So it's very difficult, in fact, to overdose on buprenorphine, especially when taken alone, because it doesn't slow down the heart rate and the respiratory effect in the same way. So when I'm teaching medical students about the unique properties of methadone maintenance and buprenorphine, I talk about doing the buprenorphine dance. I say there's a long half-life, there's a tight binding affinity, and there's a ceiling effect on respiratory suppression. Finally, I want to just speak to this issue of chemical abandonment. I really do agree with Dr. Devine that prescribing a pill or giving these vulnerable people drugs is really the easy way out. Where we need to put our resources is into recovery treatments, recovery housing, recovery communities. This is really where there's hope and where there's optimism and what these people deserve. I really do believe that to just throw hydromorphone and heroin at people without the evidence to support these interventions is a kind of easy way out and a kind of chemical abandonment. Finally, I want to just talk very briefly to the question that was asked about patients being mentally ready. One of the things that I teach my residents and my medical students, I'll say, go evaluate that person in the emergency room who's there because they're intoxicated from alcohol and in alcohol withdrawal, and see what you find out. And they'll come back to me and they'll say, Dr. Lembke, that person is not at all interested in treatment. They just want to be discharged from the emergency room. I said, okay, now I want you to wait, and then if we have the opportunity, I want you to go back and interview that person a day later or 2 days later, once they're through the worst of their alcohol withdrawal. And what my students will come back and report to me is, you wouldn't believe it, Dr. Lembke, now they're interested in treatment. What's the difference? They got through the worst of their withdrawal. They got through the chemical hijacking of their brain, which is the nature of the disease of addiction. What happens as soon as we get that huge surge of dopamine in response to any intoxicant is it's followed by a dopamine deficit state, which is what constitutes craving. And in that state, the overpowering physiologic urge to need to get more drug pushes out every other consideration. So the key there is, in that vulnerable moment, not to offer that individual heroin or hydromorphone without an evidence base to support it, but rather to offer that person addiction treatment recovery, evidence-based recovery. I would emphasize that that can sometimes be an opioid in the form of buprenorphine or methadone maintenance. But remember, buprenorphine and methadone maintenance have multiple placebo-controlled trials across generations and continents showing their efficacy in the treatment of opioid use disorder. We did not enter into those treatments lightly. Thank you so much for giving me the time to speak today.
Thank you, Dr. Lembke. We're going to open up for Q&A, but before we do that, if Member Sigurdsson could introduce himself for the record.
Thank you, Chair. R.J. Sigurdsson, MLA for Highwood. Just very glad to be here today and to hear the presentation. So thank you very much, Chair, for the opportunity to introduce myself.
Perfect. Thank you, Member. We will now open up for questions and answers. MLA Yao.
Dr. Lembke, thank you so much for taking the time to speak with us here today. What I got out of your presentation was that there might actually be different definitions of what safe supply is, and that you might support the concept that provides more clinically safe drugs like buprenorphine, which again has like things like less ability for respiratory depression than, say, your fentanyls and that, and please clarify that we need to really truly define what is safe supply and then identify what we would support in that case, and it might not necessarily be the street drugs that are being provided in jurisdictions like British Columbia.
Thank you so much for the opportunity to clarify myself, because I realize that my statements probably require clarification. So methadone maintenance and buprenorphine are evidence-based treatments for opioid addiction. They are not safe supply. How is that different beyond the pharmacokinetics and pharmacodynamics of how they work? Because they're studied and because their administration occurs within the context of a treatment setting. You go and see an addiction treatment doctor, or at least somebody who has been trained in how to administer these drugs for opioid use disorder. It is understood that you are working to get into recovery. That administration of buprenorphine and methadone maintenance occurs in the context of regular urine drug screens, regular looking at the prescription drug monitoring database and making sure you're not getting your supply, getting drugs from somewhere else. Recovery is defined as you are not using your addictive drugs. You're getting buprenorphine from me, but that's medication to treat your opioid use disorder. That's not just one more stop in your chain of drugs that you're acquiring. Furthermore, when we have patients who we get on buprenorphine and their urine tox screen continues to demonstrate that they are using other opioids, we will eventually not continue buprenorphine because we will say, this is not working. This is not helping you to get into recovery. One of the questions that was asked was, is there evidence, that was asked of Dr. Devine, is there evidence that the safe supply gets people into recovery? I don't know what that evidence is, but I haven't seen such robust evidence yet. When we prescribe methadone and buprenorphine, we are doing it in a recovery setting. We are providing treatment. We are treatment.
Supplemental?
Yeah, no, thank you so much for that. But just to clarify that rehabilitation is a complex issue. It's not just, and even a portion of it, in providing these medications to appease the physiological reaction to withdrawal and whatnot. It's not just about providing the drugs. There's a more holistic approach to this.
Yes, thank you. So again, what it does is it allows the person to get into, this is, by the way, a person who has severe opioid use disorder who has not been able to abstain, but it gets them into a physiologic state where then they are able to actively engage in recovery treatment, go to groups, go to peer recovery, get individual treatment, re-engage with their families, re-engage with their work, re-engage with their lives, right? Re-engage with their community. It's not a form of chemical abandonment. It's a way to allow people to get into recovery and re-engage with their lives and be important contributing members of society.
Thank you, member. Thank you, Dr. MLA Milliken.
Sure. Thank you, Dr. Lembke, so much for appearing here today. You are, I believe, currently a professor and medical director of addiction medicine at Stanford University. This is to say that you are, it could be considered that you're a teacher of addiction medicine at one of North America's leading universities. And I think based on some of the presentation and even in your recent answer to my colleague, that it could be viewed that you would probably take more of a holistic harm reduction type of viewpoint with regards to how to treat opioid addicted individuals. Would you be willing to, and I don't want to just put you on the spot, but would you be willing to just go a little bit deeper into your bio as to the reason perhaps with your expertise as to why you're here today?
Are you referring to the book I wrote or something else in particular?
Some of your experiences that would lend it to be the reason behind why you would be here today.
Well, I published a book called Drug Dealer MD, How Doctors Were Duped, Patients Got Hooked, and Why It's So Hard to Stop. This is a book that's looked at the origins of the opioid epidemic in the United States. It was cited by the New York Times as one of the top 5 books to read to understand the opioid epidemic in the United States. What I argue in that book is that supply or access to drugs is one of the biggest risk factors for becoming addicted and dying from drugs. Of course, there are other risk factors. There are genetic risk factors. There are developmental and trauma-related risk factors. But one of the simplest and most important risk factors to this discussion is a simple access to drug, which increases addiction at the individual and the population level. I'm also the founder of our Addiction Medicine Dual Diagnosis Clinic, which is a holistic harm reduction clinic. We prescribe buprenorphine. We believe in harm reduction, but we believe in harm reduction as a pathway to recovery.
Okay, and just to build off also what my colleague had mentioned, in your presentation you talked about buprenorphine or Suboxone being what seemed to be at least promising or valuable as part of a kit or as part of a puzzle with regards to helping individuals who are on who have issues with regards to OUD. And then my question was going to be potentially what other investments or policy kind of directions should perhaps our jurisdiction, which is going through some of the issues that obviously your jurisdiction of America is going through as well. But I think you kind of listed that. So I guess what I would do is just to take it a little bit further then. Do you have any, I guess, evidence, is there evidence or data to show that somebody who would perhaps be being treated along the lines of Suboxone use with other surrounding, enveloping, whether it's group therapy, things of that nature, whether there is a pathway through that source towards being a pathway to recovery on that, relative to perhaps any data that there might be with regards to that same recovery focus or recovery result through individuals who would be on safe supply, and then also still possibly have the opportunity for some of those other enveloping strategies as well.
Yes, thank you. So the data for the efficacy of buprenorphine and methadone maintenance in the treatment of opioid use disorder is probably one of the most robust data sources we have for the treatment of any addictive disorder in all of addiction medicine. Not only has the treatment with methadone maintenance and buprenorphine been shown to reduce the use of other opioids and illicit opioids, it's also been shown to reduce involvement in crime, reduce transmission of HIV and other infectious diseases, and to improve overall quality of life. So I think these are really, really important sources of evidence that we really have to, sort of hang our hat on, and we need to expect the same of the evidence for safe supply if we're really going to implement safe supply. And so far, safe supply has not demonstrated that to be the case. I am not aware of any evidence showing that safe supply helps people get into treatment and into recovery. That's, of course, always been the dream and the idea, but I'm not sure that there's evidence to support that. So that's why I really want this committee to be very, very careful and not get ahead of the evidence.
Thank you, Doctor. Any other questions? Oh, Emily Milliken.
I think you may have been on for the previous presenter as well, so I'll ask the same question, or it won't be verbatim, but it'll be along a similar vein. And you kind of touched on it with your response just now, but a lot of proponents of safe supply would genuinely come to a discussion about surrounding safe supply with this line of logic that every single time an individual who has OUD ends up in front of some sort of caretaker where perhaps they're being prescribed opioids, it's an opportunity for that caregiver or doctor, as one example, to try to intervene with regards to their opioid use, with perhaps sending them towards more evidence-based treatments. What would you say to somebody who would talk to you with that line of logic and say that how could it be possible to dissuade from that kind of logic? Because I've heard it from a lot of proponents of safe supply. And I think, I'm not trying to answer it on your behalf or whatever, but I think you kind of mentioned something with regards to whether or not the data bears that out.
Yeah, so I think this is what the proponents of safe supply are getting at. There's a piece of this that is true and real, which is there is a golden moment when we need to intervene to get a person with severe addiction on the right path and not on the path toward worsening addiction and death. And so the question then becomes, how do we do it? How do we do that? The way we need to do that is to lower the barrier to access to evidence-based treatment for opioid addiction and other addictions. The way that we go against that is, in fact, to, in that moment of crisis, offer things like heroin and hydromorphone, which are not evidence-based and which, as far as we can tell, just perpetuate the cycle of addiction. So the evidence is really key. If you could show me evidence that, that giving hydromorphone and or heroin allows people to become more functional in their lives, allows people to get jobs, decreases involvement in crime, decreases transmission of HIV, decreases the overdose risk, not just in that setting, but broadly in the community. We can't just look at that one data point. There's so much confirmation bias around that. We have to look at the ripple effect from those sites in the community. Are overdoses in the community going down? And I haven't seen data to show that. Further, I will just liken it again to the opioid epidemic and emphasize that pain doctors in the early 2000s, they would prescribe opioids for minor and chronic pain conditions, and patients would come back and say, "You're the best doctor, you're the only one who understands me," because, of course, in the short term, opioids are amazing treatment for pain. In the long term, they don't work, and they get people on this terrible path toward physiologic dependence and, in some cases, addiction and overdose death. But the confirmation bias there was overwhelming, such that you had this whole cohort of doctors who were desperate to help people with pain. Pain is awful. Chronic pain is so debilitating. And then in that moment of their sliced interaction, they became wild proponents of this liberal opioid prescribing. It was only when we looked broadly at the data on diversion and misuse and overdose, when we looked at it from a population level, because addiction is a public health problem as well as being the problem of an individual, that we could see, oh my goodness, this has been an unmitigated disaster.
Thank you, Doctor. Any other questions from the committee? All right. Hearing and seeing none. Thank you, Dr. Lembke, for joining us and for your presentation today. I very much appreciate that.